So my talk parallels a lot what Dr. Cole talked about, presented earlier. So I'm going to, on the fly, try to modify this presentation because a lot of the concepts have been discussed before. So the talk is framed on what are the drivers, technological drivers for patient care and for healthcare delivery right now. The second section will be how do our healthcare providers and students interact with technology, and then the third would be a guess as to what needs. Oops. What are the needs and what will the workforce look like in the future? So the drivers right now, as folks know, is patient care, obviously. Data, which you know is near and dear to my heart. Regulation. So how does regulation affect health education right now? Well, in the United States, when I was training, way back when in the dark ages, I put a note in the record, and it would be co-signed by an attending physician. I was a house staff member at that time. And our students would write a note. And I would look over the note, critique the note, and then co-sign it, and sometimes the attending would sign it, sometimes not. Well, because of a couple of poor decisions by some systems in the United States, that all went away. And physicians, attending physicians, and residents were no longer able to, quote unquote, take ownership of a student's note, and they had to write their whole note. So the manifestation of this inevitability in documentation was that health systems, not medical schools, but health systems banned their students from writing a note in the medical record at all. So it was because regulatory reasons and then legal exposure reasons and then training reasons. So it really obviously has affected medical student training at a lot of medical schools, not necessarily all. There's been some recent legislation or recent rule changes through the Center for Medication Services, CMS in the United States, which purportedly will loosen this rule, but speaking to my colleagues in Indiana and across the country, it's not clear that really will happen. Another force that's inevitable, as multiple speakers talked about, is care has moved from inside an exam room to outside the exam room. We've already seen healthcare in the United States move from inpatient to outpatient, but now it's moving into the community appropriately. And then finally, it's health versus health or sick care. So Aziz talked about high tech. So these are some of the initial objectives of high tech. Again, he reported, I think appropriately, that these effects have been questionable, whether these objectives have been met. So patient safety, we know that EHRs do promote safety, but also cause harm. And there's been several incidences in the United States where that's been documented to be true. Quality measures, the question, there's a raging controversy in the United States about how quality measures are captured and whether they really mean anything to improved health. Interprofessional teamwork, questionable. Most EHRs were really not designed for, as I mentioned yesterday, they weren't designed for care coordination. They were designed for the physician as the captain of the ship, and nobody else matters. Improved workflow, again, questionable, and patient privacy. We talked about yesterday about democratization of data, and EHRs generally have done that, and data collection have done that. But also what's happened is it's increased exposure or potential exposure of patient data to privacy. What do I mean by that is there was, unfortunately, an incident in Indiana, as a specific example, where there was a school shooting, and many of the victims came to the healthcare system where I provide care. And unfortunately, subsequently, several of our providers were let go or dismissed because even though they didn't provide direct care to the patients, they were looking up those patient records. And you'll see pretty regularly in the United States, unfortunately, folks that are being released for the same reason. So patient privacy, it's hard to go into a medical record, the old medical record facility, and find a chart, but it's really easy to do electronically. So again, one of my favorite data slides, right? So here's some factoids, tidbits about data. So it's estimated that 22.5 petabytes of data are generated daily, and it's shocking to know that since the beginning of time, since the beginning of recorded history, half the data that's been generated has been generated in the last 18 months, and that's getting logarithmically shorter. And in 2020, which is 2 years away, less than 2 years away, it's going to be, several orders of magnitude more of data driven. And again, as I mentioned yesterday, 30% is healthcare. The reason this has me nervous, the reason why I lose sleep, is on the analytics side. So we've heard lots of talk about how data will help. Well, there's also potential harm, potentially, in the use of this data. I think this is a place that health professionals need to and should take a stand for ourselves and for our patients. So some examples in image recognition. There's been huge advances in image recognition in the last 5 years. Well, there was an experiment performed at Stanford where they developed a machine learning algorithm to identify school buses versus cars or trains or trucks. They were able to manipulate a couple of pixels within a school bus image, not detectable by the human eye, that changed the interpretation of the image from a school bus to a duck. And as Dr. Cole mentioned yesterday, we don't know sometimes how these algorithms work, so we don't know why these little changes. It was an artificial situation, but it makes me nervous about how these algorithms are evaluating data. The other more interesting or more worrisome finding is in facial recognition, right? There's a great headline, I think it was in the Wall Street Journal in January. It said, facial recognition is great if you're a white guy, right? So the problem with facial recognition developed by many systems is that it was developed by engineers who happened to be Caucasian. It did very poorly for facial recognition for folks that had darker skin. Conversely, which also was worrisome, believe it or not, in the United States, law enforcement uses facial recognition for profiling. And those profiling systems were markedly biased against folks with African American origin because, unfortunately, in the United States, many of the mugshots that this system was trained on involved more a disproportion of African Americans versus the rest of the population. So it's not only about how these algorithms were developed, but it's also about what data we're using to train these algorithms. But again, if we as healthcare professionals don't step in and advocate for our patients and advocate for ourselves and advocate for better health, I think this could potentially be a problem. It was great to see all the potential inputs into our healthcare system presented yesterday by all these innovations about wearables and such. That also has me nervous. There's ProPublica and National Public Radio are running a series of articles looking at how insurance companies are using information in the United States. There's an organization called Optum, who is a subsidiary of United Healthcare in the United States. They purport to have data on 150 million Americans back to 1993. Now, we don't know how the data is being used, right? So Facebook is receiving a lot of flack for how they're using data. We do not know how health insurance companies are using this data. It's not widely publicized. They're not Facebook, so they're not in the public eye daily. But there's serious concern, right? The purported use is to provide better care. So if they use Facebook data and financial data and legal data they say they use it to provide better services for their clients, right? But think about that on the adverse way, on the adverse side. You could potentially figure out that in this zip code, we're not going to provide health care, right? Or provide health insurance because it's too expensive. Or did you just get divorced? And we know the health care costs go up after you get divorced, so for the next year or two, your premium's going up. Those kinds of concerns, those are the kinds of concerns I have for how big data is used. That is somewhat unethical. Dr. Kern brings it up appropriately time after time. There's also creepy ways that data is being used. So, pardon me if you've heard any of these stories previously, but there's a department store in the United States in the early 2010s. They have been tracking purchase patterns by their customers for years and years and years. And in one case, a young girl got in the mail coupons for diapers and for cribs and for things that a newborn will need. The father went storming into the department store, asked to see the manager, and said, I know what's going on with my daughter. She's not pregnant. Why are you sending me this information, et cetera, et cetera, et cetera. The manager had no clue what was going on, right, because all this came out of the central office, essentially, and apologized profusely. The man went home mad. The manager called up that father a couple weeks later to follow up, and the father said, well, there's activity going on in my home that I didn't know about. I'm sorry, she's pregnant. Right? So this is a department store figuring out health about their customers based on metadata, as Dr. Cole mentioned yesterday. This is not health data. This is purchase of commercial products or consumer products. So kind of creepy, creep that folks out. Well, what's the interesting follow-up is that algorithm didn't go away, right? Even though it creeped people out. So the department store got really smart, and what they did was they put those diaper and crib coupons amongst other coupons, for paper towels and soap and stuff like that, and knowing that those customers would use the coupons for diapers and for cribs and that kind of thing. So then, if you look at their marketing, their market in that particular segment went from around 22 million to about 67 million in 8 years because they were using those algorithms. So again, maybe it's not ethical. They didn't break any laws, but it's questionable whether that data should be used that way. So how does information technology interact with our students and with healthcare now? So in education, one of the things we didn't talk about or has not been brought up is how is information technology used for education, right? And I liken the current state of technology and education to healthcare 15 years ago. Like, as Dr. Cole mentioned, it was best of breed, right? We have learning management systems, and then a host of other systems that kind of interface sometimes, kind of not interface sometimes with these learning management systems. There's portfolio systems to track how our students are progressing as they matriculate through school. Sometimes they interact with the LMS, sometimes not. There's conflicts when our university LMS setup is different from the medical school or from the nursing school or from the pharmacy setup. So there's a lot of issues around technology, information technology for education. The problem is I don't foresee a compelling event like high tech in the education world, right? High tech drove adoption of information technology in the health world. I don't unfortunately see the same thing for education. And then we've talked previously about whether or not information technology is actually enrolled or an active part of education. In healthcare, we know about EHRs, the analytics, right? The analytic tools I showed you yesterday, I don't have access to as a practitioner, and I think that's necessary. And then we talked about the patient wearables and the IoT devices and social media. The other aspect that healthcare providers have to deal with, and again, this is nothing new, are the information technology services available to our patients, right? So Dr. Google, right? I've, in the last 3 months, had to answer questions about for my patients about MTHFR mutation, right? Because they got it out of their 23andMe analysis or their Ancestry.com analysis. How do we deal appropriately with communication through apps, right? There's a great cartoon in one of our local newspapers the other week. It was about a kid that had an accident and broke an arm. His friend says to him, "You broke your arm, you need to see a doctor." The kid says, "No, I don't. There's an app for that," right? So how do we deal with a generation that looks at medical problems not as an interaction between themselves and a provider, but themselves and an app? And then telemedicine and virtual visits, it's been touched on before. So the unintended consequences of IT, right? So we talked about provider dissatisfaction and provider burnout. EHRs, right, near and dear to my heart. There are lots of problems with EHRs, right? They're not designed for team care or coordinated care. Again, they were designed for the doctor as the captain of the ship. There's issues with patient safety. 58%, just a couple of years ago, 58% of their physicians hated their EHR. It wasn't like they didn't like it, they hated their EHR. It's brought work to home, right? So usually in the old days, a doc, once they left the office, they were done, unless they brought some records home to finish. Now with these EHRs being available 24/7, lots of documentation doesn't get done until the doctor goes home and stays up to 11, 12 at night, documenting missing out family time. So that's a real issue. And then we talked about regulation and oversight. As soon as data and processes were made available system-wide, it's very easy at the system level, at the state level in the United States, or at the federal level to require more and more out of doctors, and that contributes to burnout. So how does that change the way we teach our students and the kind of teams we need to develop care? So, as I mentioned, there's too many facts really, at least in medical school for sure, nursing school and pharmacy schools, most healthcare schools, to expect our students to learn in the time they're currently allotted. So I think we really need to change education from a facts learning, a fact memorizing process, to learning, a process of learning process. Sorry for the duplication. We have a hard time in medical school already, right? Because up until medical school, even through their preclinical years, they're taught, right? And they perform on right or wrong answers. You get the answer right or you get it wrong, right? And they have a really hard time, our students have a really hard time transitioning to, yeah, that's an okay answer, but this is a better answer. Or, this is a worse answer, and, there's a step above that. So how do we, they have a hard time with this gray area, which is most of medicine, and how to deal with uncertainty. We don't do that very well. The other thing we need to do is previous speakers talked about is create a massive adaptive learner. So somebody that's going to want to learn as they go on. I was talking to one of my colleagues in emergency medicine from Malaysia, and I was telling them, I practice emergency medicine. A lot of the stuff now I go to YouTube to learn. I go to a great video from Cornell or from Stanford or from Harvard to learn some technique that I was never taught in medical school, and there's no weekend symposium I can go to. There's no other source to get that information, and it's worked out very well. We need to teach our students how to deal with this care outside of the walls, right? So that's not going to be necessarily a doctor, shouldn't necessarily be a doctor. We don't know the process of how to do that, who takes what role, what's the most efficient way to deal with patients in the community. Team management, do we need teams of data scientists on our healthcare teams, right? You're not going to be, there's folks that spend time getting a master's or PhD in data science. You're not going to be able to cram all that curriculum into a nursing school or a medical school curriculum. So do we include those folks on the team? Do we include non-government organizations, folks that deal with senior care and disability care on our team? You can argue probably should. Health coaches and educators, how should they be in the team, and should they be in the team? And then again, automation, chatbots, automated log check-in, and that kind of thing. So the interesting question about team management is there is a paucity of data of how these teams should be set up. We all talk about interprofessional teams, but we don't know, there's at least no research. I'm sure health systems have done the research, but there's not very much in the way of how these teams should be configured, what it means. There's an interesting article from the Journal of General Internal Medicine earlier this year, and they looked at primary care teams for 10,000 active patients, 10,000 senior patients, 10,000 patients with increased social needs, and then 5,000 rural patients. And they figured out it costs between $45 and $65 per patient per month to care for those patients if you're going to provide high quality coordinated care. And the teams went from 8 physicians or eight physicians / advanced care practitioners and 37 or so office folks to 12 practitioners, 12 providers, and 52 administrative folks. But that's one of the few and only articles out there that actually looked at what it costs and what these teams should be comprised of. And then finally, we need to teach our students to become these policy and systems advocates, right? There's not only a shortage in healthcare workers in the world, which is getting worse, there's a shortfall of health information technology folks in the world. A dangerous combination, right? Because we need folks like Dr. Cole and the folks in the room to become advocates to make sure that these systems are set up right, they're bought for the right reason. I get warnings that just irks me to no end. I get warnings from my system about blood pressure problems, right? They want me to get my patient's blood pressure down below 130/90. Well, I'm not going to give blood pressure medicine to my 84-year-old patient who we tried to get her blood pressure down, but she fell out of bed every morning because of the orthostatic hypotension, right? So we need to set up these systems more intelligently. So we need advocates at the system level, and then we need advocates at the policy level, again, to protect our patients and protect good quality healthcare from potential misuses of data, as I discussed before. So thank you.